This is Mohammed Ali Akbar from the University of Toronto Division of Neurosurgery. And this presentation is an overview of the chapter titled Evaluation and Treatment of Degenerative Cervical Myelopathy. Overview of the presentation will include starting with epidemiology and pathophysiology, moving into understanding a bit of the natural history of the disease, how to assess and evaluate patients, management, some case studies, and then conclusion. So a bit of background, degenerative cervical myelopathy is an encompassing term for age or genetically related degenerative changes in the spinal column, leading to progressive compression of the spinal cord. Historically, non-traumatic degenerative forms of cervical myelopathy have been classified by pathology, such as cervical spondylotic myelopathy, CSM, and myelopathy due to ossification of the posterior longitudinal ligament, also known as OPLL, among others. However, the clinical picture in most patients includes an array of different degenerative pathologies that tend to overlap and are not specific to one such condition. This had led to inconsistencies in diagnosis of patients and under-recognition of the collective disease process. Therefore, in 2015, the term degenerative cervical myelopathy was introduced to represent all non-traumatic forms of degenerative causes leading to the syndrome of cervical myelopathy. And the image seen here provides a general overview of the various anatomical changes seen in DCM. The diagnosis of DCM is made when there are signs and symptoms of myelopathy in the setting of cervical spinal cord compression, as seen on imaging. So DCM is currently the leading cause of spinal cord injury in adults. Globally, it has been difficult to precisely estimate the incidence and prevalence of DCM, partly because in some cases, patient populations have been separated based on specific degenerative pathology, such as CSM, PLL, even though they significantly overlap. In other cases, DCM gets lumped with other non-traumatic causes of spinal cord injury, including infection, neoplastic disease, and vascular disease. And finally, in some studies, only paraplegic and tetraplegic patients were included. And even though majority of the patients with DCM only are mildly symptomatic, this leads to underestimation of numbers. Nonetheless, the review of literature has identified that approximately 54% of all non-traumatic spinal cord injuries are secondary to degenerative conditions. And the incidence of all non-traumatic spinal cord injury in North America is 76 cases per million. So we can therefore infer that in North America, incidence of DCM is approximately 41% per million, and prevalence is 605 cases per million. Other studies have tried to estimate the hospital admission rates for DCM and estimate this to be about 7.88 per 100,000 persons. So by any means, this is a significant public health problem and something that needs to be a focus for primary care and public health. The etiology of DCM can be subdivided into three main categories: osteoarthritic changes, including the spinal column, including degenerative disc disease and facet pathology, and non-osteoarthritic changes, the major component of which would be ligament degeneration, leading to hypertrophy, calcification, as well as ligament abnormalities, so something sort of seen in Ehlers-Danlos syndrome. The other major category would be congenital forms predisposing patients to developing degenerative changes, and this would include Klippel-Feil syndrome and Down syndrome. But there's also another way to divide these factors into static versus dynamic factors. In static factors, age-related and repetitive stress leads to disc desiccation and other changes to the internal disc properties. This manifests as disc height loss and compromise in the load-bearing properties. In turn, this causes excessive stress on the joints, initiating a cascade of changes, including osteophyte formation, ligamental hypertrophy, disc herniations, calcifications, etc. All of these changes eventually result in spinal canal stenosis and compression. Dynamic factors, on the other hand, relate to physiological movement of the spinal cord as well as pathological movements, as seen in degenerative subluxation. There is also much interest in investigating stretch-related injury in the spinal cord. Stretching can be normal with physiological movement. However, with pathology present and compression can lead to a tethering of the cord, which in turn leads to abnormal shear forces on the spinal cord tissue. If it is postulated that these stretch and shear forces in the presence of pathology can exceed the material limitations of the spinal cord tissue and lead to direct injury to the axons. Among the dynamic factors is also spondylolisthesis and just physiological neck movement and compression from that. So with respect to pathobiology of injury, some of the histopathological changes seen in postmortem studies are shown here, including demyelination and gliosis. There are some key processes or key biological processes and events that lead to these changes. And there is significant evidence to suggest that in addition to direct and abnormal mechanical forces acting on the spinal cord, reduction of perfusion to the spine secondary to these forces also plays a key role in the process of injury. So ischemia is thought to be one of the major mediators of injury in the spinal cord with chronic compression. And the thought is that the chronic compression leads to direct deficit in perfusion by compression of the spinal vasculature and the penetrating arteries. This is further exacerbated by pathological changes in the vessels themselves, as evidenced by post-mortem studies showing wall thickening and luminal hyalinization in the anterior spinal arteries. Ischemia, in addition to compression onto the cord, induces endothelial disruption, which leads to compromise of the blood spinal cord barrier. And disruption of the blood spinal cord barrier, or BSCB, exacerbates microglial activation and macrophage infiltration into the cord parenchyma, leading to inflammation. And there has been much research done or being done to delineate these inflammatory pathways to find main targets. For example, postmortem studies have shown that expression of a CX3CR1 receptor, which is a receptor, a major mediator of microglial activation, was found to be overexpressed in DCM patients. And these inflammatory pathways may be important in targeted therapy in the future. Finally, the chronic ischemia, the inflammation, and the disruption of the blood spinal cord barrier through a cascade of intra and extracellular events leads to programmed cell death in the neurons and the oligodendroglial cells. And as you can see in the figure here, ischemia mediates all of these processes independently and can lead directly to apoptosis as well. So in addition to the processes listed, Henderson et al. Have also postulated that stretch and shear forces on the spinal cord by themselves may also lead to ischemia because of these shear forces and tethering. However, this has not been proven or verified in animal models or in vivo studies. So now that we have a better understanding of the pathophysiology of the disease, let's talk about the natural history. This is where we do not have enough information. The natural history of DCM is highly variable, and most data on DCM has been obtained from retrospective or underpowered prospective studies. Traditionally, we know that although some patients with DCM will have stable neurology, a large number of patients exhibit a progressive and stepwise decline over a time period. And a large systematic review published in 2017 showed that about 20 to 62% of patients with DCM experienced some neurological deterioration over a 3 to 6 year follow-up period. In this case, clinical assessments were done using the MJOA, which stands for Modified Japanese Orthopedic Association scores. This is an investigator-administered tool to measure functional outcomes, and we will discuss this a bit later. In this setting, clinical deterioration was described or defined as a decrease of 1 or more points in MJOA. This review also identified some clinical predictors, including circumferential compression on MRI scan as being associated with deterioration. Other factors such as duration of symptoms, female sex, and increased neck range of motion were also identified, but the systematic review did not find sufficient evidence to support prognostic utility for these. Okay, so we'll talk about now the assessment and evaluation of these patients. So any evaluation of a patient suspected with myelopathy should undergo a detailed clinical history and examination, as well as clinical imaging that is appropriate and electrophysiological studies. Starting with the clinical assessment, this will include a detailed history of present illness, where common complaints may include neck pain, radicular pain, weakness, numbness in the limbs, clumsiness or loss of dexterity in the hands, difficulty with walking or balance, And finally, frequency, urgency with urinary or bowel function. On examination, the clinician should perform an extensive neurological exam in addition to the appropriate focused examinations where needed. This should include looking for upper motor signs such as hyperreflexia, positive Hoffman's, upgoing plantar reflex, and signs of spasticity. Other signs of myelopathy may include motor weakness, atrophy, specifically in the hand intrinsic muscles, dermatomal numbness or sensory loss, and broad-based unstable gait. Functional impairment can also be assessed. In this case, there are subjective and objective tools. The subjective tools include the MJOA, which is Modified Japanese Orthopedic Association scale, as well as the NURC grading system. Both are clinician-administered indices. The MJOA is a 18-point score covering 4 subdomains, including upper extremity motor function, lower extremity motor function, upper limb sensation, and stricture function. The MJOA is a modification of the Japanese Orthopedic Association scale, which was specifically designed for the Japanese population, and the MJOA was developed as a more standardized measure for accounting for cultural differences. And MJOA is currently the widely accepted outcome measure, despite its limitations, including poor sensitivity and a modest inter to intra-rater reliability. These subjective measures have their limitations, especially when dealing with mildly symptomatic patients where subtle changes may not be detectable. But these are the widely accepted standard measures. There's also objective measures such as the graded redefined assessment of strength, sensibility, and prehension, also known as GRASP, which is a standardized test to assess motor strength and prehension and coordination in the upper extremities. The caveat being that this is a time-consuming test, needs specialized equipment as well as training to be conducted. So moving on to imaging, this is a vital tool in the assessment of DCM. Currently in the clinical setting, conventional imaging such as plain X-rays, CT, and MRI are ubiquitously used. MRI is the study of choice and the best modality to visualize spinal cord and soft tissues. It's valuable in identifying the level, degree, and type of compression on the spinal cord. It can help rule out other conditions on the differential. And in some instances, MRI may also show signal change within the spinal cord. This can be T2-weighted hyperintensity or T1-weighted hypointensity. T2-weighted hyperintensity is more commonly seen, but it's a less specific marker because it could relate to a lot of different physiological changes, including gliosis, edema, demyelination, myelomalacia, or necrosis and cavitation. On the other hand, T1-weighted signal hypointensity, it tends to be more specific, representing permanent changes in the spinal cord parenchyma, including necrosis and cavitation. So having both of these markers on imaging are associated with poor surgical outcomes, meaning there has been significant injury to the spinal cord. The other common imaging modality is plain X-rays. This is a quick and efficient, economical way for visualizing the spinal column. It can provide valuable information for spinal alignment under physiological loads because it's done upright, and can also be used to identify any instability under dynamic loads during flexion and extension. Computed tomography like X-rays allows for better visualization of bony anatomy. It's usually or commonly used for surgical planning in spinal instrumentation and navigation. CT myelograms can also be used as an alternative diagnostic tool when MRI is contraindicated, but it only shows you the subarachnoid space and not the spinal cord tissue itself. Other advanced imaging techniques have also have potential in the future. Most of these are MRI-based techniques and generally being referred as quantitative MRI. Quantitative MRI is a collection of techniques that allow for extraction of quantifiable metrics from the spinal cord tissue or soft tissue. Some of these methods, such as diffusion tensor imaging, have been widely used and adapted to the brain. These techniques have been so far mostly used in research capacity. However, in recent years, extensive work has been done to identify potential imaging biomarkers for spinal cord injury, and these metrics have been shown to be more sensitive and then clinical outcomes and measuring or detecting myelopathic changes and progression. The main issue with clinical translation of these techniques has been the time it takes for image acquisition, as well as the technical challenges of acquiring the imaging and processing it. Finally, the electrophysiological assessment can also be a very important diagnostic tool. Electromyography, or EMG, is one of the oldest methods of diagnosing nerve root compression and can detect anterior horn syndromes. The positive findings are often reduced recruitment of motor units and identified through delayed high amplitude or polyphasic potentials. Active denervation can also be seen on EMGs. Somatosensory evoked potentials, also abbreviated as SSEPs, and motor evoked potentials as MEPs, can be used to detect prolonged conduction in specific sensory or motor pathways, respectively. So SSEPs would be more dorsal columns, and MEPs would be corticospinal tracts. For SSEP, stimulation is applied transcutaneously along a peripheral nerve, and recording is made on the scalp with electrodes. For MEPs, the stimulus is transcranial, and the reading is recorded from a transcutaneous electrode. The findings manifest as latency or low amplitude waves. These tests are useful in detecting subclinical changes in asymptomatic patients, and MEP may be more superior in terms of sensitivity compared to SSCPs in detecting signs of myelopathy in asymptomatic patients. Both can help identify patients who should be monitored closely for deterioration. Finally, the last one is contact heat evoked potentials, or CHEPs. This is a technique that can assess damage to central sensory nerve fibers in the spinothalamic pathways. CHEPs is a more sensitive technique compared to SSCPs and allows for dermatomal testing as well. SSCPs, MEPs, and EMGs can also be used during intraoperative monitoring, and there is strong evidence that multimodal intraoperative neuromonitoring is sensitive and specific for detecting intraoperative neurological injury. So once the diagnosis of DCM is made, now we move on to management. So there's two possible scenarios: non-operative treatment and operative treatment. They're not mutually exclusive. Patients who undergo operative treatment may then also have a non-operative therapies for rehabilitation. The AO Spine North America and Cervical Spine Research Society published clinical practice guidelines in 2017. These guidelines were developed by combining an extensive literature review and clinical expertise from members. The guiding principle here is the severity of disease as measured by MJOA. So asymptomatic patients whose MJOA is 18 and have evidence of cervical spinal cord compression on MRI scan should be counseled for red flag symptoms and signs and monitored closely. If these patients have radicular symptoms present, then after an appropriate non-operative trial with rehabilitation, they can be offered surgical intervention for the radiculopathy. For patients with mild DCM defined as MJOA of 15 to 17, the evidence or quality of evidence is weak. And we know that up to 62% of these patients will deteriorate in a 6-year period, but it's difficult to determine which patients. Currently, the recommendation stands to offer surgical intervention or decompression with the alternative of a supervised rehab trial with close monitoring. Again, the quality of evidence here is low, and this is because we have a large population of patients with a quite variable number of them who could deteriorate and some who might not. So we need to delineate this population a little bit better. With respect to the moderate and severe DCM patients, in the bottom two rows, the recommendation is for operative treatment or offering operative treatment, and the evidence indicates that early surgical intervention is beneficial and that surgery is quite effective. So let's start with the non-operative treatment modalities or therapies. There are some options from a growing list with very little evidence to support any specific one with respect to MJOA change. However, there's something to be said about having a organized and structured therapy program that can potentially help patients physically and mentally by providing a management roadmap that can assist in setting expectations down the line. Starting at the top, Patients can be counseled to reassess vocational and day-to-day activities and to address posture, form, and also avoiding high-risk activities such as contact sports. Physiotherapy, manual therapy, specifically the former, can help reduce pain as well as improve cervical alignment and strength. It shows the most benefit in mild DCM population. However, there is still a role for regimented rehab in moderate to severe cases in postoperative patients. Third, the pain is often a large part of the morbidity experienced with these patients, and a multimodal approach to pain early on using a combination of non-steroidal anti-inflammatories, neuropathic pain agents, acetaminophen, and local anesthetics may help reduce narcotic dependence. Although a recent there's also other experimental therapies that can be used. Within these, there's maybe two big categories. One is neuroprotective agents, such as riluzole. This is a sodium channel blocker used in ALS. And although a large randomized controlled trial of riluzole in DCM patients did not show any change in postoperative NJOA improvement, it did show a reduction in postoperative pain in follow-up. So it can be used in the pain management or to prevent pain complications down the line. There's other regenerative therapies such as therapeutic protein injections, stem cell injections, and gene therapy. The latter helps regulate appropriate interdiscal gene expression to delay degenerative changes. And these are all being investigated in animal models, and none of them are in clinical trials. So there's some promise there. Some of these treatment modalities can also be used as adjuncts in addition to operative treatment and for postoperative rehab. So now comes the operative treatment. Patients who have moderate to severe DCM qualify for some sort of surgical intervention with the aim of providing optimal decompression of the spinal cord and nerve roots, as well as to maintain structural stability and alignment. Surgery has been shown to be effective, not only in preventing further deterioration, but also in improvement of neurological function. This is after two large prospective studies, the AO Spine North American and the AO Spine CSM International studies, showing these results. So the approach and the type of surgery can be decided based on multiple factors: clinical judgment, patient preference, and the diagnostic and imaging criteria. There are various anterior and posterior approaches. Anteriorly, the option is of the anterior cervical discectomy infusion, anterior cervical corpectomy infusion, or a combined procedure. Posteriorly, decompression can be performed using a laminectomy procedure with or without fusion, depending on how extensive the decompression is and what the cervical alignment and stability is. Laminoplasty is also an option for posterior decompression. It involves reconstruction of the posterior arch and expansion of the canal, but the procedure lends itself to better outcomes when patient selection is very selective. And some of the criteria that can be used includes patients who have preservation of their cervical lordosis, any absence of axial pain, and any signs of instability. In terms of efficacy, when patients are selected appropriately, both procedures, laminectomy and laminoplasty, have similar efficacy. And the discrepancy in preference for one procedure over the other is primarily geographical, with laminoplasty being more popular in East Asia. Lastly, with severe and complex disease and instability, a combined anterior with posterior approach may be performed. So if you ask which approach is superior between the anterior or posterior, currently there is no evidence to support one over the other. At the end of the day, this would be based on patient selection and surgeon preference. However, there is a large randomized controlled trial that is ongoing to determine if this is true in cases where there is equipoise management. So once we have the results from this trial, we can better answer this question. So the type of surgery selected depends on various factors, including surgeon preference and comfort with a specific technique or approach, patient characteristics and comorbidities, direction of pathology, number of levels involved, and cervical alignment are all very important. So multi-level disease may be better addressed by a posterior approach, but the cervical alignment and its restoration should be an important point of consideration. There are objective radiological techniques or markers that can be used, such as the C2 to 7 sagittal vertical alignment or modified K-line that can assist the surgeon in determining the alignment of the cervical spine. C2 to 7 sagittal vertical alignment is defined as the distance between the C2 mid-vertebral body plumb line and the most superior dorsal aspect of the C7 vertebral body on lateral radiographs, and normal would be within 35 to 40 millimeters. The other measuring technique is a modified K-line, which is a vertical line drawn from the mid-C2 spinal cord to the mid-C7 spinal cord on sagittal MRI. If the most ventral aspect of the anterior pathology is within 4 millimeters, which is within 4 millimeters of the line, then a posterior approach is unlikely to adequately decompress the spinal cord, and an anterior or a combined approach should be considered. And on the images here on the left, you can see how the C2 C7 SVA is measured, and the modified K-line is drawn from C2 to C7, and the distance between the most ventral aspect of the anterior pathology and the line is the minimal interval distance, and it should be less than 4 millimeters to recommend the anterior approach. In terms of decision-making, multiple levels are possibly better addressed from posterior approach. However, multi-level ACDFs have been shown to be effective and safe and are commonly done. Presence of OPLL with preserved lower doses may be addressed posteriorly, and there are other scenarios such as these. So we would like to go over some case examples highlighting briefly the decision-making process for surgical approach. In the first case, we have a middle-aged female presenting with signs and symptoms of myelopathy with moderate DCM. So her MGOA is 15. Her MRI scan shows a multi-level disease with loss of cervical lower doses. You can also see the spinal cord signal change, so T2 hyperintensity at C3-4 within the spinal cord parenchyma. If you draw a modified K-line, you can see that the pathology intersects the K-line anteriorly, and the minimal interval distance is less than 4 millimeters by definition. And in this case, it is likely that a posterior approach would not adequately decompress the spinal cord, given the amount of kyphosis. Therefore, in this patient, the decision was made for a C4 to C7 anterior cervical discectomy and fusion, and the postoperative MRI shows there's been a correction of the kyphosis, and the spinal cord is adequately decompressed anteriorly, and the pathology has been addressed directly. In case number 2, similar to the last patient, we have a middle-aged male with now severe DCM and an MGOA of 10. The MRI shows, again, multi-level disease, but slightly different anatomy. The stenosis in this situation is concentric, and the compression is from anterior and posterior directions. The cervical alignment and ligament hypertrophy posteriorly is contributing to the problem. Drawing a modified K-line, we can see that the minimal interval distance is greater than 4 millimeters. This would indicate that an anterior approach would not be able to adequately address the issue. So in this patient, the decision was made to do a C3 to T1 posterior decompression and instrumented fusion. And the postoperative MRI shows the results with excellent decompression. The lower doses has been reduced slightly. But the objective of the procedure is to decompress the spinal cord. So multiple studies and summary of literatures has been conducted to produce some outcome prediction models and predictors of outcomes postoperatively. So far, from review of literature, we know that there are some major factors that are associated with worse clinical outcomes. And this includes longer duration of symptoms before diagnosis, higher severity of myelopathy preoperatively, and finally age, the latter being inconsistently associated with worse outcomes. There's also minor predictors, which have limited prognostic utility, and the exact mechanism of how they affect outcomes is not well understood. These include history of smoking, comorbidities such as diabetes, psychiatric disease, and finally obesity. So the major clinical predictors is what are important right now, and they emphasize the need for early diagnosis and intervention. So in conclusion, some of the main points that we would like everyone to take home are: number one, DCM is a progressive neurological disease manifesting from compression of the cervical spinal cord due to various degenerative and compensatory pathologies. DCM is the most common cause of spinal cord disease in adults and should be a greater focus for public health and primary care, given the aging population. We know that early diagnosis is likely to improve outcomes. So diagnosis, number three, diagnosis is made clinically in the presence of myelopathy and signs and symptoms in any 4 domains, including upper motor, lower motor, gait, coordination, sensory, and bowel bladder dysfunction. Signs and symptoms in these 4 domains, in addition to compression of the cervical spinal cord on imaging, is how the diagnosis is made. Number 4, we have still not fully understood the natural history of DCM, more specifically that of mild DCM. However, multiple studies have shown that in moderate to severe cases, surgery can be very effective, not only preventing worsening, but also leading to improved neurological and functional outcomes. Number 5, surgery. The surgical approach, anterior versus posterior versus combined, should be tailored to each specific case independently, depending on the history, anatomy, and stability, as well as surgeon preference for one or multiple procedures. Finally, some of the knowledge gaps include, as mentioned, the natural history of the disease, and longitudinal studies have already begun in order to delineate some of these questions and answer them. The second is improving our search for predictors of outcomes, as well as imaging biomarkers. And again, multiple studies have began and are almost in completion in order to provide us with better biomarkers and better predictors of outcomes. And lastly, with regards to optimal choice of surgical approach, a large randomized controlled trial is underway to determine the best approach when there is equipoise in management. So with this, we hope that the presentation has been educational, and we wish you the very best. Thank you very much.